Dr. Siebert's next talk, the left atrial appendage occlusion.
Okay, so my second talk is about left atrial appendage occlusion, and I was asked to talk about overview of devices and techniques. This was the first device we used to close the left atrial appendage, the Pluck device, and that was already more than 12 years ago in August 30, 2001. That was a patient who is now 84 years old, and since then he is off of anticoagulation, had zero bleeding and zero embolic events. The technical success rate with this initial device was already 94%, and periprocedural major adverse event rate was 5%. What is very important that we followed all these patients and we did not see any device-related complication beyond 30 days, which means when these devices are healed in, there are no late complications occurring. This gives you an overview about the different devices which have been invented and used since then, and they can be divided into two groups. One is the endocardial devices, and the other one is the epicardial techniques. Let's start with the Watchman occluder. It's a 19-hole frame covered with a PET membrane. It has hooks to stabilize the device in the appendage and comes in different sizes, as you can see here. This shows you an example of a TE, a typical left atrial appendage, in 45 and 130 degree in TE. You can see the pigtail is in the left atrial appendage. We usually perform REO 30 degree and REO 30 degree with chordal angulation, and then the device is introduced. It's difficult to see on fluoro, but you can see the device on the TEE. We do a tug test to make sure that the device is in a stable position, and we also measure the residual compression before we release the device. You can see the device is released now in TEE as well as in angiography. Well, with this device, more than 2,000 patients had been studied in different clinical trials. The most important trial was the randomized PROTECT-AF trial, and we now have 4-year follow-up of this trial. Well, regarding effectiveness, which is stroke prevention, LAA closure has been shown with Watchman, has been shown to be superior to warfarin. So after 4 years follow-up now, LAA closure is superior to warfarin regarding stroke prevention and even regarding mortality. Regarding safety, adverse events, left atrial appendage closure is non-inferior to warfarin, and most complications after LAA closure are pericardial effusion without long-term sequelae. You can see the primary endpoint, prevention of stroke, death, and systemic embolization, and you can see the two curves of the Watchman device and control group, and you can see that LAA is now superior, is better than anticoagulation. And this is true for almost all subgroups of this trial. And this is another aspect here. Mortality is reduced by left atrial appendage compared to anticoagulation. It's significantly better than anticoagulation regarding mortality. You can see the safety endpoint. Again, we had some initial safety issues, and this is mainly pericardial perfusion, and that's why these curves divert here early on, but later on these curves are merging, and now after 4 years, Watchman LAA occlusion is non-inferior to warfarin. And actually, within the PROTECT-AF trial, we had all the learning curve issues. And when you look at the early phase of PROTECT, the late phase of PROTECT, and the CAP registry, which was the second trial after PROTECT-AF, you can see that all the adverse events decreased tremendously. Another device which has CE mark is the Amplats cardiac plug, and I just heard this device has already approval here in India. It's made of a 19-hole wire mesh. It looks a little bit like the ASD or VSD occluders from the same company. Lobe diameter is between 16 and 30, and disc diameter is between 20 and 36 millimeter. You can see an example how this device is implanted. You can see how the umbrella is closing off the orifice of the appendage, and you can see the angiogram and the TE after release, and you can see how nicely this device closes the appendage. There had been a trial with this device, not randomized. It has been a prospective monitored registry with independent adjudication. The technical success rate with this device is also 90.6%, as with all the other devices. The adverse event rate is in the same range as with the Watchman occluder. The Amulet is the second generation of this device, which has a number of technical advantages compared to the ACP. For example, it has more stabilizing wires in larger devices, which increases the stability. It also has a delivery cable, which includes a thinner wire, which enables evaluation of the final device placement prior to release, so the device can be observed there in a tension-free state. Again, no idea who put that slide up here. So the Coherence Wavecrest device is another device which is has a CE mark or will have it very soon, and the advantage of that device is that it allows distal contrast injection, and it allows separate placement of the device and the anchors, so the anchors are rolled out only at the time when you think the device is in a good position. Aquatec, another new device which is still in animal trials, human study, will start very soon. It has loops instead of hooks. This may reduce the incidence of pericardial effusion, and it has a flexible connection between the delivery cable and the device. Sedaris Patch is a device which is basically a device-free technique where a latex balloon is inflated and then collapses over time. This has been used in humans, and it has basically CE mark. This is a Chinese company, LifeTech, has developed a very interesting device which is actually very easy to implant even in difficult morphologies. The human trial has started and is ongoing. PFM, a little different concept. This has a distal anchor and then a connection part and then an umbrella which closes off the orifice. Again, with this device, first human trials will start this year. The Cardia Device is following the same principle, a distal anchor which is at the apex of the appendage, and then a flexible connection and an umbrella which closes off the orifice. 4 patients have been treated successfully with this device. So Gore also is working on a device. They're in a very early stage. They told me looks very promising, but there are no pictures available because all this is very much top secret. So let's move on to the epicardial techniques. There are basically 2 techniques which have been used in humans successfully. One is the Aegis concept, which has a grasper which has electrodes for EKG recording, which allows you to identify the position of the grasper, and then the tissue of the appendage is grasped, and thereafter a suture wire loop is advanced over the grasper, and with this wire loop you can close the appendage. First in man has been performed in October last year in a small number of patients. The Lariat device is actually much more advanced, and this is a combined transeptal and transpericardial technique where a transeptal catheter is introduced into the appendage right here, and then a snare is advanced over a pericardial axis. You can see how the snare is closed down, and I will play this again on TE, and then you can see how the appendage is basically disappearing when this snare is closed down. What is published and data with this device, 119 patients were screened, 89 patients were attempted, success rate again 96%. You can see the adverse events which occurred in this trial, and complete closure after 1 year was observed in 99%. So in conclusion, with the PROTECT AF trial, we have the proof of concept that LAA closure with the Watchman is superior to anticoagulation with Coumadin. One other device, the ACP Amulet, has CE mark and seems to have comparable results. Other devices are available in clinical trials, and transpericardial LAA closure with the Centre heart is a technique which allows to close the LAA without the device. Thank you very much for your attention.
Perhaps just any questions from the audience? Availability of new anticoagulants. Does it change the picture at all for you? Have you seen that impact in terms of potentially bleeding risk, convenience factors, and other things? Does that change who gets closure? In your mind, is there anyone that shouldn't get closure? One, and two, are there better subsets than others?
Okay, so does the appearance of new anticoagulants change the picture? Well, it does not change anything for those patients who are contraindicated.
Sure.
Because those patients who are contraindicated for Coumadin, they are also contraindicated for the new drugs. What's about those patients who could take both? And these are the patients who had been evaluated in the PROTECT-AF trial. That's a little bit an open question. I think it depends upon the time of follow-up. And that is because, as I showed you, there are no late complications of late atrial appendage closure, whereas with anticoagulation, there are obviously late complications because you still have the bleeding risk, and the bleeding risk is increasing with age. So when you look at 4 years, Watchman is superior to anticoagulation with Coumadin. It may be that because the event rate is a little bit lower with newer drugs, it may be that you need more time to be superior to new anticoagulants. So you may want to ask for randomized trials if you want to do that. You probably need 5-6 years when you look at the data, 5 to 6 years until you will be superior.
And you went through sort of a parade of devices, both intracardiac as well as pericardial. You have access to multiple devices. Are the majority of cases can be done with any device, or are there a lot of anatomic features? And is there a large learning curve? So if people want to do this, in terms of what is the learning curve in terms of the imaging and choosing which approach you take?
Okay, these are basically two questions. One is, are there advantages of one device over the other device? Well, theoretically, there's one advantage of the Watchman, that we have solid data for that. We don't have this for all the other devices. From the technical point of view, there are limitations of all these devices. For example, for the Watchman, you need a certain landing zone, a length of landing zone. With the ACP, you can close even shorter appendages. And when it comes to the transpericardial access, the advantage of the major advantage, in my view, of the transpericardial access is that there is no device left behind, which means some of the complications which can occur with the devices are just not existing. For example, thrombus formation on the device cannot occur, and also device embolization cannot occur because there is no device. Coming to the question of the learning curve, this is a procedure everybody can learn. But I think it's a little bit more difficult than, for example, PFO or ASD closure. And if it comes down to numbers, I would guess that after 20 to 50 cases, people feel comfortable to do this alone without a proctor or without some clinical specialist from the company.
Great. And what is your anticoagulation strategy in the short term after device, let's say intracardiac device implantation, and what is your follow-up strategy? Do you routinely image all of these patients with the TE at a certain time point, or clinical?
So first question is medication after LAA closure. In the PROTECT-AF trial, it was mandatory to treat these patients for 45 days with Coumadin. We have learned from studies with other devices and also from practical use with the Watchman device that this is not necessary, so we prescribe only aspirin and Plavix. And this has also been confirmed to be safe in the ASAP trial, which was recently finished and published. So, to answer your question, aspirin and Plavix for 6 months. Follow-up, we always do a 4 weeks and 6 months TEE. First of all, to make sure that the appendage is really closed, because if you have a big residual flow, then you have to continue with medication. And second, to make sure that there is no thrombus formation on the device.
Great. Any questions from the audience, either technical or data-driven? And I know there's been a big push in the U.S. after the PROTECT-AF, the 4-year results. And a lot of people have started to say, well, there's this inherent bias against device in the U.S., and we don't have approval yet. But now it's not just, and I think that's one of the key things to emphasize, it's not that it's equivalent, but there's a mortality benefit. at 4 years, which is surprising and stunning to a lot of people. And hopefully this will sort of move forward. And I think, we really need to reassess and revisit. It's not a convenience factor, it's not anything else, but, at this point it shows a mortality benefit.
This is one of the very few procedures we actually do in interventional cardiology showing a mortality benefit beside TAVI. Many other procedures we are not able to show that.
Wonderful. Thank you so much.